Hi everyone, I'm Pepe Eulzer. I'm with the University of Jena and I will talk about a fully integrated pipeline for visual carotid morphology analysis today. So let's first get you covered on what we are working with. The carotids are the two major arteries that supply the brain, and they often develop plaque or fatty deposits over time. Atherosclerosis might be a familiar term to some. And these plaque deposits can impede the blood flow and ultimately cause a stroke. This is particularly harmful in the internal carotid, which is the brain supplying branch of the carotid. So ultimately, what we want is to derive a better understanding of this process and to see if a stenosis should be surgically treated or not. The prevalence of severe extracranial carotid stenosis is about 4% in adults, and this approaches 16% after the age of 65. This means that in Germany alone, we have currently over 1 million patients with above 50% carotid stenosis. So in other words, we have 1 in 80 people that have a high risk for stroke due to carotid stenosis. Just for comparison, in Germany, we have about 200,000 ischemic strokes, so strokes due to stenosis or emboli every year, and the largest part, about 30,000, are due to carotid stenosis. So the question is, what can we do to prevent these deaths? And the answer is regular screening. We can do preventive surgical intervention, which is sometimes possible, and it's very important to determine the necessity and the type of the treatment. For screening options, what is usually applied is either or both Doppler ultrasonography and angiographic imaging, primarily CTA. Based on these imaging modalities, we can determine key decision factors, which are then used to decide further treatment. So one of these factors is the patient symptomatic. Can we find stenosis? Where can we find them? And then we can determine, or usually the stenosis degree is determined, where there are widely applied guidelines that are used to recommend surgery. So how does the screening work? I will go through a simple example here. The neurologist transfers the patient to the CT. Then the CTA and some other images are recorded, and these are sent to a radiologist. And then the radiologist determines if stenosis are present, which degree they have. So they look at the image slices, they follow the relevant vessels, and if a stenosis is suspected, then the so-called NAST criteria are applied. For the NAST computation, you take the minimal diameter inside the stenosis and you compare it to the normal diameter of the stenosis or after the stenosis, and you plug this into a formula, and you get the stenosis degree. And if the stenosis degree is above 70% and the patient is symptomatic, then surgery was shown to be highly beneficial for the patient. So let's have a closer look, because the procedure is not quite as simple as it first looks in the textbook. Here we see that the CTA, or here we see a CTA that shows a stenosed carotid bifurcation. May have highlighted it there. And you can see how determining the best position and measuring a diameter here is very difficult, and it's also very subjective. So it's not even really defined what is a normal post-stenotic diameter, and choosing this value can have a huge impact on the result. Also, the stenosis degree tells us nothing about the plaque composition, the accessibility, or the shape, the length, the position of the stenosis, and so on. So the question is, how can we enhance this process? And there are many ideas, from vessel visualization and medical image processing. These approaches either use volume rendering, so the image-based approaches, or they use models, which we call model-based visualizations. There are a lot of advantages of model-based vessel visualization. So the overview of the vessel shape is vastly more intuitive. You get, or what you can do is an automatic or an objective classification, as I will show in a minute. And there are ways to incorporate additional information, for example, information on the blood flow. The problem is that these techniques are very difficult to implement and practice. First, because complicated processing is necessary for feature extraction, classification, visualization. And second is we also have kind of the reverse problem. The accuracy of the geometric models somehow needs to be validatable. So to actually apply advanced vessel visualization in clinical context, we need a very stable and a very sound system that fulfills not only a good data viz, but also an efficient workflow for data extraction and data validation. Digging deeper, we identified 4 major challenges when it comes to the clinical adoption of advanced vessel visualizations. First is the trust in the encodings. So how do I know what I see is even true? Second is the efficiency. How fast can I get to a result? Then we have compatibility. How specific are the data formats? Are standardizations available, for example? And last but not least, validation scale. This is often overlooked. In many studies, we only have a handful of example data sets that are used during development. And these can lead to biased algorithms that scale then very badly when new data is introduced. The question we asked is how can we approach these bottlenecks using the example of carotid morphology analysis. And what we do is we propose an integrated, adaptive, modular pipeline framework. So integrated means that processing and visualization can be done in one coherent framework, which fosters the understanding and trust in the processing steps. Adaptive means that edits in earlier pipeline stages can be made retrospectively, so they propagate, edits propagate automatically if possible, which greatly simplifies validation and correction of the data. Then we apply a minimal data interface, which leads to higher compatibility. And with modular, we mean that the pipeline is secluded in processing and visualization stages, and thus can easily be extended with further processing or viz modules. I'll give you a quick tour. First, we import a DICOM series of a new patient. We get an overview of the full image volume here. And then next, we find the carotid bifurcation. So we do this by finding a specific point in the dataset and then selecting a region, a crop region that we will then use for further processing. Now, to create a 3D model of the vascular structure, we need a segmentation of the inner vessel wall. And we trained and integrated a convolutional neural network that can be called with the click of a button here. And this CNN generates labels for lumen and plaque in less than a second. And then we can check these labels immediately, and also the 3D model, as you can see, is extracted on the fly. And if it is necessary, you can also do manual corrections in this stage. We also have one feature extraction module implemented, which gives us additional information for subsequent visualization stages. So what we have here is an integrated centerline generation. The user marks the in and outgoing branches, and then the centerline is solved automatically. And we also compute the inner vessel radius here as a byproduct. And as you can also see, the result can be verified immediately. So we show the centerline here that is computed. What can you do with the processing results? So we provide one example, which is a classifier module. On the left, you can see a plot of each inner vessel diameter that has been computed. So we have one plot for each branch. And on the right, you can see a model with where we have highlighted the stenosis candidates that the user has selected here. So if you hover over the plots, you can see the affiliated branch that the plot corresponds to. And then the plots can be used to identify regions of interest and mark possible stenosis. By brushing over the plots, you can reveal a stenosed region in the 3D model. And we also immediately compute a stenosis degree in that selected region. The advantage here is that we can find a global minimum algorithmically, which is highly accurate when it comes to determining the stenosis degree. Now, if you remember the location, we also needed a second diameter to compute the stenosis degree. And this location that we need here is the normal diameter, which is not really defined. But with the tool, what you can do is you can choose the location of this second parameter live, and you can see how that changes the stenosis degree used. So you can choose an adequate position for the second or the comparison diameter. The core advantage of the integrated pipeline is that you can do on-demand validation and correction. So at any stage, you can go back and fix errors. For example, you can adapt the segmentation mask, and then the result is automatically propagated, and you can immediately work with the corrected model. Now, this vastly increases the efficiency as compared to workflows where we have these stages split across multiple tools. And we found that integrating this visualization and processing into one framework can be highly beneficial. So let's talk about the results. We interviewed 4 neurologists. We gave each of them 3 unprocessed datasets, so CTAs from the clinic, and they used the framework to evaluate and discuss any potential stenosis that occur in these datasets. So they worked through all the processing stages by themselves, and then they rated the workflow, and we discussed the clinical applicability. Here you can see the results of the questionnaire, and I won't go over everything, but I just want to highlight some of the impressions that we gathered here. So what we learned is that just having a model available as compared to only CT slices or volume rendering could actually make a huge impact, because understanding the morphological features and the plaque distribution, the stenosis location, etc., was very helpful for our participants. We also found that the trust in the visualizations is significantly increased if the users can validate and check the models on the fly. And lastly, we asked if the users would rather trust the radiological report or the computed value regarding the stenosis degree. So we showed them what the radiologist said what the stenosis degree is, and we also had them select the stenosis degree or read the stenosis degree from our tool. And remarkably, all 4 of our participants stated that they would think that the computed value is more accurate. So the reasoning behind that is they said that they can see that the model aligns with the CTA data, and that they trust the machine to find the smallest diameter here. So in conclusion, we showed how the concept of the integrated adaptive and modular pipeline architecture can be used. So we pair all pre-processing and vis stages of an analysis process, and we could show that by giving stepwise visual feedback, we can increase user trust in the results, and trust is extremely relevant for adoption and usage in medical applications, of course. We applied the pipeline to the context of stenosis classification, where we could demonstrate that the extracted models can be used to interactively detect and classify stenosis very quickly and very reliably. Now, we focused on carotid stenosis and particularly stenosis morphology, but the same concept could be extended to other tasks or transferred to other domains, like, for example, aneurysm evaluation. The pipeline is currently used in 2 major studies that investigate pathophysiology or pathological progression of carotid stenosis. And until now, we have over 100 carotid bifurcation models that were extracted from real patients with this pipeline. For anyone interested, this carotid model database, we also made it available online. So you can go and use the models yourself, and you can also find here the carotid analyzer source code. And you can use the code to implement extensions for yourself as pipeline modules. And with that, I thank you for listening.